So we have shock from our low blood pressure and our vasodilation and our capillary permeability. We have disseminating intravascular coagulation going on from our white blood cells trying to kill our E. coli, but also harming our cells. But we also have septic shock is associated with acute respiratory distress. So why is this? Well, the lungs are highly vascular in order to oxygenate the blood. Since all of this damage is happening systemically, it is also happening in the lungs as well, making it difficult to acquire oxygen. This is going to be our third problem. So we're having low blood pressure, DIC, now we're having difficulty acquiring oxygen. Cardiac output will initially increase to combat the decrease in blood pressure, right? So our pulse rate's going to go up to help combat that drop in pressure. However, the cardiac tissues are no exception, and if left untreated, it too will be impacted by sepsis, and cardiac output will begin to drop, adding to a drop in blood pressure. So problem 4. So we have a drop in systemic blood pressure. We have this kind of continuous coagulation going on in the blood. We have an inability for the lungs to effectively capture oxygen and transport it into our red blood cells. And now our cardiac tissue cells are starting to be infected by our antigen, and our cardiac output will begin to drop, further adding to our loss in blood pressure. Patients with an infection typically have a fever, right? Because as we know in our initial conversation, the innate internal system will try to drop some pyrogen hand grenades to increase our body's temperature to hopefully burn off the infection. So patients with an infection typically have a fever. At first, a septic patient will have warm skin, but as sepsis progresses, the sympathetic nervous system will clamp down the vessels to improve perfusion because, again, we have a lot of vasodilation, and we're losing this battle, both perfusion and infection. And this will obviously not improve the perfusion due to the increased capillary permeability of the vessels. But blood will be shunted away from the skin, making the patient cool to the touch. So as the infection goes on, maybe what this patient we would think should be feverish will now not feel hot to the touch because their body is now trying to shunt blood as they are progressing down the shock tunnel towards death. This will also end up having patients present with respiratory distress and altered mental status as their perfusion further decreases. So, bad stuff. Now, sepsis kind of happens in steps. It's not that all of a sudden we go from a healthy patient to someone who's in septic shock. There are clues along the way, and we should know these. So, sepsis or septic shock comes in steps. Now, sepsis itself is defined as life-threatening organ dysfunction caused by dysregulated host response to an infection. In other words, we're having massively poor perfusion to our organs, causing a wide range of organ dysfunction because our body has been trying to contain this infection but is unable to, and doing what it's supposed to be doing is not working. It's causing a systemic problem. So the first step of sepsis, we can call it systemic inflammatory response syndrome here, or SIRS. You've probably seen some stuff about like this in your protocols or reading about sepsis as some of the symptoms that may be a part of it. Now, again, as I said, we want to focus a lot on our population as well. So sepsis really comes down to a really good assessment, starting out with our susceptible populations, and then next looking for these signs and symptoms of systemic inflammatory response syndrome. And this is typically 2 or more of the following, but the ones here in blue a temp of 100.5 Fahrenheit or less than 6.8 Fahrenheit. So we could have patients that have a fever, but we could also have patients that are hypothermic. This is especially true in children. So watch out for that. We're also going to have patients that may have a heart rate above 90. They may not necessarily be tachycardic, but their heart rate will be elevated. Their respiratory rate will also be elevated to be above 20. They would have a high white blood cell count, which we can't do pre-hospital, so that's out. And if you have a lactate monitor and you are able to take lactate in the field with your system, you would have a serum lactate that's above 2 millimoles per liter. So what I would say is if you end up having someone who is in a susceptible population with a temperature that is above 100.5 or less than 96.8, and maybe they also have a heart rate above 90 or a respiratory rate above 20, you could start thinking as one of your differential diagnoses, systemic inflammatory response system. What I'll also add, and some of these will kind of more fall in with sepsis, but they should be on your radar right off the bat, is patients with altered mental status. Because sepsis should be a differential diagnosis for altered mental status, especially in our elderly population. A blood glucose, because we all have blood glucose monitors, a blood glucose that is greater than 120, and this is a kind of a soft assessment, but it can help confirm maybe an infection due to a stress hyperglycemia. But be cautious that the symptoms are not related to hyperglycemia or DKA. So as the body is stressed from the infection, they may have a release in glucose, causing a bump in blood glucose. But again, keep this, with our patient. If we have a patient that's a diabetic or someone that we may suspect is hyperglycemic or DKA, they could be having all these symptoms, and we could be thinking about treating them for sepsis, but they're in DKA. The next one too, obviously, hypotension or a MAP below 65. This is going to obviously lead us down towards the road of shock. But we have someone who has a low blood pressure that doesn't seem to be explained by trauma or cardiac. We could start thinking about sepsis. And also, if we get them on end tidal as well, if we get end tidal below 35. End tidal that is less than 35, this can be due to an increased respiratory rate, as we had talked before, as one of our signs up here. It could be an increased respiratory rate from respiratory distress, or could be metabolic acidosis due to poor perfusion as sepsis carries on.